So this is in a particular order because I'm basically going from top to bottom, and I'm going to start with Shar. Shar, there's several questions around small fiber neuropathy and its relationship symptom-wise with peripheral neuropathies, and how you assess for that and how you might treat that.
I just wanted to ask the question again.
Yeah.
How do you differentiate the two, or?
Yeah, can you differentiate the two with your tests, and what are the treatments?
So someone like Dr. Saperstein that is specialized in small fiber neuropathy, I'll engage them. They'll do the QSAR testing to differentiate the small fiber. I think that the space of evaluating and diagnosing nerve entrapment, nerve compression, I haven't seen many of our colleagues that are doing a comprehensive evaluation for nerve compression. Yes, there's going to be some corollaries and some, on the Venn diagram, similar presentation. The testing for small fiber would be the skin testing and QSAR testing, and the testing for nerve compression would include, but not limited to, nerve ultrasound, a detailed history, peripheral nerve exam, sensory motor proprioception, Tinel evaluation, possibly dynamic ultrasound, and magnetic resonance neurography.
So we're really taking a very clear history and then engaging in all of those differential diagnosis sort of tests to try and get a better feel for whether it may be a compressive neuropathy versus more of a sensory neuropathy.
Yes.
Yeah. Brilliant, thank you.
Because a lot of the previous data and a lot of the previous presentations were that a lot of the neuropathies in EDS patients were related to small fiber and are predominantly sensory.
Yeah.
However, I haven't seen much literature, and I look forward to being part of that investigative team in actually documenting motor and sensory exams and performing a complete peripheral nerve evaluation of those conditions.
Yeah.
I think it's just not been evaluated and documented properly to see what's the prevalence and incidence of that.
Yeah, thank you very much for that. Thank you.
Thank you.
Shilpa, there's this is actually more of a general question around supplementation, which might also apply to comments around causes of neuropathies. But it's around the use of supplements as part of pain management, non-pharmacological pain management, and whether blood tests should be checked for people who are taking certain supplements to make sure that there isn't any interaction between them. The complications, basically, of supplement therapy for pain management.
This is kind of a controversial question.
Are you on?
Hello?
Yeah.
A bit of a controversial question, and probably my answer is probably not going to be clear-cut either, but the role for supplements is if you have a deficiency. So if you're going to take supplements and you don't have a deficiency, I'm going to say it's going to be of limited value.
So I know from talking to some of our nutrition colleagues that actually using blood tests as a way to try and determine whether there is or there isn't an actual deficiency is a very ineffective way of trying to work out what's going on. Because there can be some insufficiency, but you're not going to see that on a blood test.
I think if you have a vitamin B deficiency, you're going to see it.
Yeah.
Things like that you are going to catch. So if this is specifically about zinc, I still don't know the answer. Fiona?
So one of the things that we've seen with things like zinc, for example, is the absolute need to make sure that you're measuring copper, that you're measuring iron, because you do not want those interactions to cause negative problems with any of those supplements. So you could go the wrong way by trying to do the right thing, and you, I think, generally have to be really, very careful. Can I just ask about your experience in peripheral neuropathies in terms of nutritional deficiencies and vitamin deficiencies?
Absolutely. So we try to work with our nutritionist, and a lot of the complex patients, we engage the nutritionist as well. And I definitely agree that there's going to be some of the agents. We've had great experience with the alpha lipoic acid 600 milligrams daily basis. Our Hand Society literature on vitamin C after wrist fracture and decreasing post-operative pain. So we're on the supplement standpoint, I think globally, from a surgical society, it's going to be a newer frontier aside from what I just mentioned on alpha lipoic acid and vitamin C. However, I do provide evidence-based knowledge for our nerve-injured patients regarding the other supplements and working in conjunction with our nutritionist to ensure that the safe doses are administered and the monitoring is proper.
Thank you. Yeah, it's really working in a multidisciplinary way.
Absolutely.
I've been given the all clear that we're okay outside, so we can stick to time. I'm going to come to Patty and Amy. Questions from people around having respiratory symptoms, rib cage concerns, fixed scoliosis. How do you work with, Amy's like, yeah, you knew this one was coming. How do you work with people who've got those fixed conditions as part of their underlying connective tissue disorder when you're working on that diaphragmatic work that you were describing?
Go ahead. So that's my wheelhouse. That's what I love working with. So with a scoliosis, it's a triplanar problem. So you need to be able to determine if there's how much rib involvement there is. Some people have more, some people have less. But even with an asymmetrical rib cage, you can get more efficiency. It's not perfect. And if the person is young and does not have a fixed curve, it all depends on how tight the rib cage and the vertebrae are, and if there's more tightness in the ligamentous system around that area. Of course, there'll be more hypermobile above and below the curve. We can affect that through breath work. The big thing is not mobilizing it, but more trying to get mobility through stabilizing through muscular action at a different portion of the rib cage, and then directing the air to the area that needs to get more expansion so that it's internal pressure to be able to get the mobility. So you really should, if you have a scoliosis, try and seek somebody who's been trained in working with scoliosis to help you with that. But you absolutely can improve the respiratory pattern, and that's the whole philosophy behind the Schroth protocol and the SEAS protocol. It's all about diaphragm and breath.
Thank you. Anything to add there, Patty?
No, she's my scoliosis expert.
She's
I'm
the
more of the
expert.
organ expert.
Can I just add an extension to that around pectus excavatum or pectus carinatum? Do you see those as particularly issues in this context?
For scoliosis, absolutely. And I think that one of the big risk factors for compression syndrome is hypermobility and scoliosis, or kyphosis, any kind of spinal deformity, which includes the pectus.
Yeah, thank you. I'm going to come to Kevin. Kevin, a question around trying to differentiate functional neurological disorders from the dystonia that and by the way, what an amazing result. Congratulations on that lady. So the functional neurological disorders from dystonias, and how you help patients to work their way through that, and help clinicians to work through the differentiating between these two very different issues.
Sure, that's where I think you need a village kind of to be on board here with it. I always like to examine, treat what is the outcome, and if we're making progress, I keep going. I keep going. There's a lot of functional problems that are out there that can be manifested from it. And I think that needs to be included in this with other providers and seeing is this something that others can help with, or is this something that can be helped with different brain-based type of therapies? So I just go with the outcomes.
No.
And if I could real quick, you mentioned something about like nutrient supplements and stuff like that. What I found, and I'm going to keep this real quick, if the gut isn't working, it's tough to get the stuff in for it to work.
Right.
That's why I kind of keep coming back. If you can get the autonomics good, what I've seen from nutrition, PT, OT, whatever, you get that, things go a lot better. They respond so much better. I don't want to take anybody's time here, but I mean, that's just, that's what I've seen.
Yeah, thank you for that.
Sure.
Shar, there's been a couple of questions around upper limb neurological signs and the whole relationship with thoracic outlet syndrome. Just wonder what your experience is of seeing that and what the kind of therapeutic treatments are for that.
So classically, thoracic outlet was described by vascular surgeons, and it's actually, this area is called, it's anatomically the thoracic inlet. The outlet is actually more distal, but nevertheless, the area that's above the clavicle and in the anterior triangle of the neck is one area where both the vessels and nerves could be compressed. We look at thoracic outlet from a vascular standpoint, from arterial, venous, and from a neurogenic standpoint. So from the diagnostic pieces, in addition to the detailed history and peripheral nerve and vascular exam, we'll do dynamic nerve testing and MR neurography to look for structural areas that are mechanically compressing the structures, in addition to vascular testing with arms at side, 90 degrees and 120, to look to see if there's an occlusion of the subclavian artery, subclavian vein, and augmented by MRV or MRA to look for an actual occlusion. Then moving towards, first we want to establish the proper diagnosis. We have to remember that the plexus, or this area, you can have compression above the clavicle, under the clavicle, or in the transaxillary space. So assuming that the diagnosis is related to neurogenic thoracic outlet, and we've identified if the compression is, for example, above the clavicle, we're gonna start, and we rule out any craniocervical instability, atlantoaxial instability, and the C-spine is clean. Then we're gonna start with our physical and hand therapist in stretching the scalene muscles, the pectoral muscles, rhomboid muscles. So in essence, we're looking at the upper trunk, middle, lower trunk, all of the nerves and muscles and structures that are around the neck and shoulder region. First with stretching, with nerve gliding, postural training, and then if we see that the patients have a good response to that, they continue with that course. If we see that there's still pathology, and we also eliminate or rule out double crush or polycrush symptoms, meaning nerve compression distally. Could it be cubital tunnel as well, carpal radial tunnel? We want to make sure those are eliminated in the evaluation. Then we proceed to some of the diagnostic injections. In non-EDS patients, we classically look at Botox injections of the anterior scalenes. And then Botox, we have to be mindful of that in the use of our EDS patients. Then in addition to that, some of the newer regenerative techniques that we utilize depending on the affected nerves on perineural PRP. And the evidence of that is new and it's being developed. And ultimately, if patients fail all of these non-operative modalities, then we consider nerve decompression surgery.
Thank you. There's a whole textbook on the management of thoracic. That's
yeah,
perfect. Thank you so much.
I authored that with you guys, right?
And you authored it.
Yes, I authored it. Yeah.
No, it's fine. I've now been told I have a minute left, so I'm going to give my last question, if I may, to Amy and Patty. This question comes up in relation to the diagnostic tests that are used for MALS, and somebody says that it's positive and somebody says that it's negative. And I can imagine you probably have come across this in your clinical practice. And I wonder what your kind of approach is when there are different opinions for the ultrasound type diagnostic tests versus your clinical acumen. Maybe explore that with us. Patient comes along, 2 different people have told them 2 different results for the ultrasound. How do you take them through that and make your decisions as to how best to manage them?
That is the future of what we're working on, is to be able to teach other people how to do that. So this was really just trying to introduce that we need alignment, we need the proper biomechanics, and we need to get neurology checked out in some people. For Amy and myself, I think it's much easier because we don't necessarily need a positive test. We need to know what's dysfunctional, what their limitations are, where their pain is, and we just have to treat that. We just need to know where to look. So I do think that we have it easier for us because we're not considering surgical treatment. That's not our field. So we have so many different options, and we are trying to put together tests that any therapist can do. We've been specially trained, and that's what we're trying to sort out right now, is what is appropriate for a therapist that might not have gone through years of experience, but might be able to do in the clinic. So that is coming in the future.
Yeah. It reminds me of exactly of the story around craniocervical instability and the use of dynamic imaging. There's a huge amount that can be learned from the skills that you guys have in terms of your actual physical assessment versus an imaging modality in terms of what's going on. Just finally, I thought it was really fascinating in Sandman's paper how doing the scans in different postures seemed to identify, risk in certain people. I guess this rings true in the work that you're doing, that correcting those abnormal postures is absolutely fundamental to the management of this.
And I know that we have posture issues in this population, but it is fair to say that we're seeing consistent posture issues with these individuals in certain areas. And that's what we would like to continue to work on so that we can show, yes, it's absolutely, it's a posture problem.
Yeah. Well, look, we've only had a very short time to go through some really amazing areas with some incredible people. Round of applause for everybody, and thank you so much for your time and your expertise and your care. Thank you.
Thank you.